Hello, good morning, all. Can you hear me? If you can hear me, maybe you should just wave your hands. Let me be sure I'm audible enough. All right, thank you very much and welcome to today's early eco session. It's nice to have you again this week. Just a quick one. I want to ask that all the facilities on the call should please turn on your video. We want to see you. CIHP Gombe, we can see you and we celebrate having you. Please, can we turn on our videos, send in your attendance as usual using the chat box. And for individuals, as much as you can, we also encourage you to turn on your video. And please, to those that are yet to join the call, kindly extend the invitation to them and have them join the call. Thank you very much and welcome again. They will be looking at a very interesting one on recency surveillance data use. Most of us are heard about surveillance, the case-based surveillance, mortality surveillance, recency surveillance, and even the drug-resistant surveillance. So today we are looking at one of the aspects of the surveillance. We have a very renowned subject matter expert that will be speaking to us today. But before then, I'd like to call on the Federal Ministry of Health to give us an opening remark. And we have standing by to do that Mr. Ikulono Gabriel, who is Research, Surveillance, and Survey Lead at NASCAP. Mr. Ikulono, you might want to unmute yourself and let's hear you. Mr. Ikulono, are you there? Can you unmute yourself and let's get the opening remark from the Federal Ministry of Health? Mr. Ikulono, I don't know if you are there or anybody from the Federal Ministry of Health. All right, we can't have Mr. Ikulono. Please, let's go on with a goodwill message from CDC Nigeria. And we have to do that Dr. Matthias Alagi, who is the team lead epidemiology and surveillance. Dr. Matthias, please, can we have you unmute yourself and go on with a goodwill message from CDC?
Good morning, everyone. It's a delight to be on this call, especially today's learning section that has to do with recent infection surveillance. And we want to implore you all to pay attention because this is one of the global best practices with which you can apply to getting to the ends of HIV/AIDS epidemic in Nigeria and even globally. It has been a proven technique for tracking and identify people who are at risk of new infections, their contacts, and people who are newly infected, so that they are, for those who are newly infected, they are identified and placed on treatment. For those who are at risk of infection, they are identified and offered prevention services so that they don't get infected with HIV/AIDS. So we want to implore you all to pay rapt attention to the sections that will be delivered by the expert, and you should be able to apply this to your areas of practice, either in the facility or in the clinics or community, wherever you operate. You should be able to apply this knowledge to your area of practice so that we can all both jointly get to the ends of HIV/AIDS in Nigeria. Thank you very much, and over to you, Prosper.
Thank you very much, Dr. Matthias, and thank you for all your support from CDC and the guidance you provide. Thank you so much. We have Dr. Ayola Nihi Uri Sawai, who is the program manager surveillance and implementation science at the Institute of Microbiology, Nigeria, who will be speaking to us on today's topic. I believe he will do justice to that. We want to make it more practical for those who are not, who are new to this, so that we can grasp all he's saying. So, Dr. Nihi, it would be nice to have you. Can you please share your screen and let's have your presentation? You have about 30 to 5 minutes to present, and then we'll use the rest for questions and reactions. Thank you very much, Dr. Nehi. Over to you, please. Dr. Nehi, are you there?
Yes, Prosper, I'm here. Good morning. Thank you very much for having me this morning. Please confirm if you can see my screen.
Yeah, we can see, but can you put this in projection mode and then increase your voice so that we can hear you clear?
Okay, so can you see it now?
Yes, although you are using a projected screen. And
Okay, let me just quickly change it. What about now?
Perfect, it's good now, perfect.
Okay, thank you very much. And I also thank Dr. Matthias for that introduction. I think he has given a summary of what we're about to do here today. So we just go right into it. So today we'll be talking about recency surveillance data use and specifically our learning objective.
Dr. Nee, can you increase your voice? It's a little bit low. I don't know if
Can you hear me now?
Yeah, we can hear you, but just increase your voice or speak directly to the speaker. Thank you very much.
Okay, I'm doing that. Please confirm if I'm loud enough now.
Yeah, it's better now. Thank you.
Okay, thank you very much. So I said today we'll be talking about recency surveillance and data use. And the learning objectives for today are number one, to highlight the essential information derived from HIV recent infection surveillance, and also to understand use cases for HIV recent infection data, and to know the appropriate response to HIV recent infection. So we'll be starting with the global HIV epidemiology. We know that as at the last UNAIDS data, globally, we have 38.4 million people living with HIV globally, with 1.5 million new infections in 2021. And we have 32% decline in annual new infections between 2010 and 2021. So there has been a gradual decline from 2010 in the number of new infections and also the number of AIDS-related deaths, which means gradually we are moving towards that point where we talk about epidemic control. And in Nigeria specifically, we currently have 1.9 million estimated people living with HIV, according to the UNAIDS data. And we have 1.3% prevalence among adults, 15 to 49%, 1.9% among women, and 0.9% among men. And that's according to the NAIS 2018, which I'm sure almost all of us here are aware of. And the estimated incidence among adults 15 plus is 40 per 100,000 per year. Now, recent infection surveillance, the global mandate is that as countries move closer to epidemic control, real-time monitoring of recent HIV infection is important, and this will allow us to target public health response to locations and subpopulations where high levels of transmissions are occurring, even though for most of the countries, we're at the point where we can start talking about epidemic control, but there are still pockets of geographies, subpopulations where we still have ongoing transmission, and identifying patients that are recently infected, in an ongoing basis will help us to be able to identify this location, get our services or our programs towards addressing that area. But again, what is HIV recent infection? We've had the presentation, I think sometimes early this year, that we talked about HIV recent infection, but just to bring to our remembrance that a recent infection is defined as an HIV infection acquired within the past 12 months, approximately. So what that kit that we use for identifying this recent infection, what it does is that it tries to identify those clients that have been recently infected. So these are new infections within the past 12 months. And the long-term infection is defined as an HIV infected infection acquired more than 12 months. So basically, these are long-standing infections, not new infections. Now, we also need to talk about the other part. We're talking about recency surveillance. So what is surveillance? What is public health surveillance? It's the ongoing systematic collection, analysis, and interpretation of health data essential to the planning, implementation, and evaluation of public health practice, closely integrated with the timely dissemination of this data to those who need to know. So what we do in HIV recency surveillance is that on an ongoing basis, we collect information about ongoing recent infection. That's very important, unlike what was done in a survey like NAIS, that we need to wait for years before we're able to know those that have recently acquired the infection. But now that this has been integrated into our program, in form of surveillance, so we can collect this data, on an ongoing basis, analyze this data, interpret this data, and most importantly, use the data, because without data use, we cannot say that we're implementing surveillance. So when we implement, we use it to plan, to implement, and also to evaluate public health practice. So that's essentially what a recency surveillance is all about. Now, in Nigeria, the goal of recent infection surveillance is to use a rapid test. And what we use specifically is the Asante kit, the rapid test for recent infection, to provide continuous epidemiologic data on person, place, and time of newly diagnosed individuals age 15 or older to inform HIV prevention and control strategies in the country. So basically, we implement recency surveillance among those that are 15 and above. And again, there are also other eligibility criteria that we use before we can test individuals for recent infection. And just to bring to our remembrance again, one of them is that this patient must be a patient that is being diagnosed for the first time, not a patient that has been diagnosed a long time ago. Because if it's a long-standing infection, then why are we testing this individual? I already know that this patient was identified, for example, maybe 2 years ago, and you want to be testing the client again, whether the client has started treatment or not. So there's no need to test such clients again. And for clients that also have signs and symptoms of advanced HIV, we already know that those are not new infections, because it takes a long time before the patient can come down with AHD. So for those that are having signs or symptoms of AHD, or that the CD4 count already tells us that this patient has AHD, they are also not eligible. Those that are already on treatment too are not eligible, even if we're sure that they've recently been diagnosed or they've recently been diagnosed. But once they've started, treatment, they are no more eligible. And these are some of the eligibility criteria that we need to painstakingly, try to elicit from our patients before we test them for recent infection. Now, the recent infection, so why test for recent infection in the first place? I've told us some of them, but just to ensure that we drive home the point again, number one is to identify areas of ongoing HIV infection. Which place in geographies, in communities, or subpopulations are we having ongoing HIV infection? Because whenever you have someone that has be recently infected with HIV, it means that number one, someone has infected that patient, and it's likely that person that infected that patient may not even be on treatment, or may not know his or her status, or may know his or her status but not on treatment, or may even be on treatment and not virally suppressed. So there are possibilities, and for this to have gone on, we need to be able to identify where this patient is coming from, try to see the reasons why there's ongoing HIV transmission in that area. And also, number two is to be able to improve prevention and treatment programs, because if we don't do that, we're not able to achieve epidemic control, and to be able to track epidemic trends and inform HIV incidence estimates. So those are the reasons why we test for recent infection. And we have domains of data use in recency surveillance. We have essentially 3 domains. The first one is monitoring data for quality. It's important that we use quality data when we are talking about using any data for program planning, for implementation, or to be able to improve our program. we must ensure that the data we are dealing with is of high quality. So number one, the data has to be complete. The test that we are carrying out must be of very high quality. We're able to monitor, the quality of the test that is being done. We must be able to make sense of that data. You must be able to look at your data and say, this data makes sense. Then we can use it for the purpose that we want to use it for. So the aspect of monitoring data for quality is very important. And even in our program, we ensure that from time to time, we test, the ability of the tester to be able to, give us, high quality testing. And we also ensure that the data completion, the data has been submitted to be used for surveillance purpose is of very high quality. So that's one domain. Another domain is to be able to monitor data for impact. Essentially what we're talking about, we're able to use the recency surveillance data to support HIV epidemic control. And in doing this, we use it to characterize the epidemic. So where is this epidemic still, taking place? Who are those that are, that are affected? Who are those that there is ongoing transmissions among them in terms of age, in terms of the characteristics of the individuals, maybe their KP, maybe, their MSMs, you need to be able to characterize the epidemic. We also need to be able to characterize the epidemic in terms of time, where and when and who are affected. Once we have done this, we're able to act on the recent cases. We'll be able to know for the individual cases, to know what to do for each of the individual cases and also their contacts. And we can even take it further to look at what is happening above the site level and be able to use that information to guide public health response to better target risk. Because we have limited resources and, from year to year, these resources keeps reading. So we must be able to maximize the use of the limited resources that we have. And recency surveillance data will help us to do that. And we also must be able to monitor data for progress. That is the third domain for recency data use, then surveillance data use. Monitor for progress. We must be able to have indicators that monitors where we are. Where are we coming from and where are we going to? So from time to time, we want to look at this indicator. Are we really ensuring that our program ensures that we are going towards zero case of HIV infection? So we must be able to come up with those indicators that are very sensitive. We're able to measure, for progress with time. Also interpreting data in the context of the epidemic control. Now, let's look at this scenario together. We have a client XY who presented in a facility AB and offer HIV test. The client had positive results following the testing algorithm. Additionally, the rapid test for recent infection indicated a long-term result. So the question we want to ask ourselves, what is the implication of this result? This patient has a long-term result, which means that this patient's result is long-standing. So what is the implication? The patient was likely infected in the last 12 months, or the patient was likely infected more than 12 months ago. Now, question 2, in your experience, how likely is it that this client has had an HIV test in the last 12 months? Is it very strongly? Is it probably? Or very unlikely? So I want us to ponder on these questions. Look at your facility or the community that you implement HIV testing or recency testing, and try to look at what happens using your data compared with what is happening here. So we look at that, this first scenario. So what's the implication of the result? What is the result trying to tell us? So we mentioned earlier on that long-term result tells us that this patient was likely infected more than 12 months ago. But if it is recent infection, that is the RTRI recent, it means that this patient has been infected in the last 12 months, approximately. So the second one is one that I want us to ponder upon, to just look at how we implement and the possible, explanation for this. Is it likely that this client had an HIV test in the last 12 months? So you know that most of the clients that we have, usually it's possible that one client that has tested in one place, they go to another place to go and test again because they are not sure about the result. And sometimes, even when they are sure about the results, they still go to maybe prayer house to go and see if the test result can be reversed. Those are some of the things that we have. But sometimes, because they don't have symptoms, they just decide not to be on treatment until they start having symptoms. So when you look at your practice and just try to answer these questions in your mind. Now, from the scenarios, important things to note is that as we inch closer to achieving epidemic control, contribution of newly infected clients to the pool of PLHIVs yet to be identified and placed on treatment becomes more significant. Also, tendency for client-initiated repeat testing among previously identified positive and people already on treatment is high. So just like the point I made earlier on, sometimes someone that he or she knows our status already will still be moving from point A to point B to go and repeat that test. Sometimes some patients have been on treatment, but because of maybe poor counseling, or maybe they were counseled well, but still they are still doubting that they are going to be on drug for life. So they try to see if the drug that they've been on for some time would have cured them. So sometimes they carry out studies where that's the reason why some patients try to initiate repeat testing themselves. They feel that they've been on treatment for a very long time, and it's possible that they are cured. How does recency test help to address all these issues? Now, what happens when a client is identified to have a long-term infection? When long-term cases are identified, we can do more to rule out previously known positive clients and possibly are already on ART by intensified post-test counseling. So once a patient is already long-term, we test the patient and it's long-term, we must ask ourselves, what are the possible scenarios? Is it possible that this patient has done his own status, or this patient is even already on treatment? So that information will help us to do intensified post-test counseling to find out if the patient is already on ART, so that we not be counting the patient again as if the patient is newly identified. And this is some of the reasons that we have a lot of long-term in our program. And I'm sure you're already aware that we are also dealing with a patient duplicate patients are already on treatment in one facility, they go to another facility, to go and initiate treatment again. So this recency testing can help us identify those patients at the point of post-test counseling. So if that patient is long-term, we want to counsel the patient again and say, oh, okay. So again, essentially ensuring that our counselors, how will I put it now? Our counselors have the ability to be able to identify those clients already on treatment, and this research can help us to do that. Also to reassure clients that if they are previously known or even on treatment, they will receive help and support. Because sometimes the reason why patients do this, they feel that if they disclose their status, that you may not want to initiate them on treatment, or there may be issues, so we need to reassure them that if they disclose their previous status, we'll be able to help them, they'll be able to receive their support. So what happens when a client is identified to have recent HIV infection? So a patient that has HIV infection, so we've said already, that is a client that has been recently infected. Now, effective epidemic control requires early detection. So it's important that we detect early. And by detecting that, infection early, it will help us to interrupt the chain of transmission. You know, when you look at epidemiology of transmission, the early you detect cases, the early you are able to intervene, and the more cases you are able to prevent. So it's just like breaking that chain of transmission. So effective epidemic control requires early detection, longitudinal follow-up of each case, and quick public health response. Now, when you detect HIV infection, including recent infections, you want to analyze the data. You want to, as I've said earlier on, you want to characterize in terms of who, where, and why. That will help you to target prevention, and that will also help you to interrupt further transmission. So this is just to build the basis for recent infection. Now, the most important thing after identifying this recent infection is to be able to respond. And in Nigeria, we have 3 levels of response. We have the individual response, which is done at the site level. It's the real-time response for every individual recent infection. So for every recent infection that's identified, there are things that we need to do for them to provide their transmission and risk network with appropriate services to interrupt transmission. And our major focus in this presentation today will be on the individual response, because majority of people that are here actually from facility. We're trying to build capacity of those at the facility to be able to know what to do for every recent infection that they identify in the facilities. But beyond the individual response, we also have the above site response. And this above site response is near real-time intervention on specific time-space clusters or groupings of recent infection cases in order to disrupt ongoing transmission. So this is done by personnel that are not site level personnel. They are done at the state level or maybe the local government level, where we try to see how many cases have been identified in a particular geographic location. In our own context at the local government level, that's where our above site response is. So at the local government level, we try to see how many cases have been identified in a month, and if it has surpassed the threshold, you begin to investigate. You want to know those hotspots in the local government where the transmission is ongoing. You want to ensure that you confirm the data that is being reported. Just like we talked about the domain of a data use, you want to investigate for quality data. Once you are able to say that, oh, this is quality data, then you want to go ahead and see if you're able to identify the hotspots and to know the drivers of infection in that particular geographic location. Then you can now go ahead and carry out targeted testing, with some wraparound services. So that's what the above site response is all about. But the national response is also important. About the national response, the data is reviewed to inform policy decisions and resource allocation to address gaps and enhance HIV prevention and treatment program. Now, as I've said earlier on, I said we're going to be focusing on the individual response. Now, for the individual response, there are things that we do for the recently for the RTRI recent patient. That is for the recent HIV infection index case. And just like Dr. Batas mentioned in his introduction, we also look at the contacts of this patient. There are things we also do for the contacts of the patients. There's what we call the risk network. Risk network, consists of those that are connected to the index case that are either HIV positive or that are already known or that are negative. That's the risk network. And that's what index testing tries to help us to do. So we take that recent infection that we have identified as an index recent infection case, all right? And these are the services that we offer to such a patient. We want to ensure that we prioritize same-day ART initiation, just to do for every other patient. We want to ensure that we prioritize same-day ART initiation for this client. We know that there are contraindications, sometimes to same-day ART initiation, and basically they are all around AHD. I told you earlier on that anyone that has ART is not a recent infection. So that's already eliminated. So same day ART institution is very, very important, because as I've said earlier on, that this recent infection, they occupy a very important epidemiologic status in the community, because number one, usually they have very high viral load, so they can transmit easily. And someone has also infected them that may not be virally suppressed. So you must ensure that this patient starts ART immediately, so that you reduce the time for this patient to become virally suppressed. Also, we want to emphasize U equals to U messaging for this client. We want to prioritize this client for linkage support services. We want to prioritize this client for index and partner notification service. In fact, this is very, very important. We want to ensure that within 14 days, we identify all the recent, all the contacts of this index recent case, so that you can also, address their issues, depending on their own classification. Is it already, known and already on ART? Is that the patient is negative? Is that the patient, is also a newly identified patient? So you want to prioritize this for them. And one of the issues that we see on the field is that sometimes when contacts are elicited, we hear things like, so we couldn't reach the patient is far, the patient, the index case was identified in Benue, and the contact is in Lagos, so we couldn't reach, the contact. We often say that once a state in Nigeria has not attained epidemic control, every other state is at risk, because people are very mobile. And sometimes you find out that even the individuals that you identify in one state, they actually migrated from another state, or they are just passing through that state. It's important that we do index testing, not based on IP or facility basis. So we can reach out to other IP. So if the patient is not within your own jurisdiction, you can do, out of jurisdiction communication, reach out. So we have these contacts of this index case. Can you help us to locate and, to offer, ART service, HTS services to that client? So we must start thinking about how to ensure that we carry out index testing in such a way that we don't just limit it to our own area of jurisdiction. Then you have to provide HIV self-testing for partners who cannot be reached. So if that partner cannot be reached, so through that index case, you can provide HIV self-testing for such clients, so that the client, can screen himself or herself, and ensure that and it goes for diagnosis if the result of the HIV self-testing is positive. Now, I've talked about the out of jurisdiction communication. Also needs to to follow up, closely every index recent infection case to ensure that eventually they become virally suppressed. You need to place them on ART. You also need to follow them closely for partner notification services. If the patient is a member of the KP group, you want to offer social network testing through KP services, including mobile voluntary counseling and testing. You also want to provide specialized services for populations with additional needs, e.g. pregnant women, breastfeeding, adolescent girls, young women, people who inject drugs, just according to the national guidelines. And we expect that the outcome for this particular service is that this patient is initiated on ART the same day. This patient is virally suppressed by 6 months, and all partners are traced and offered HIV and recency testing within 14 days of being elicited. So we have to ensure that that is done. And again, index testing is not a one-time approach. We need to continue to elicit their contacts, their partners on an ongoing basis. Now, for those partners that are eventually identified, or contacts that are eventually elicited, you also want to characterize them, just as I've said earlier on. They form part of the risk network. So for those that receive HIV tests and are newly diagnosed HIV positive, those partners, that received HIV, you're able to reach them, you're able to test them, and you find out that they are newly diagnosed. You want to also ensure that if they are partners, that they receive recency testing at the time of HTS. So it's like you're starting the circle all over again. So this is someone that's a contact of a recent HIV positive client. So you also want to ensure that once they are positive, you conduct recency testing for them. You also emphasize you equals to you messaging. You offer them in-text testing and part of education services. And if it's a member of a KP group, offer social network and testing through KP services. And for partners and children, you want to ensure that you link them with support. You offer them family index testing. They also initiate them on ART the same day. Then the outcome is also ART initiation same day, viral suppression by 6 months. All partners are traced and offered HIV testing within 14 days of being named. And if they are HIV negative, those contacts are HIV, you test them and they are HIV negative, you want to ensure that they remain negative. So it's important that you counsel them on prevention services. You want to offer them condoms, risk reduction services. If they are injected, they are PWITs, you want to ensure that you offer them risk reduction services. Just depending on the kind of clients that they are. If they are eligible for PrEP, you want to also prioritize them for PrEP according to the national guideline. You want to ensure that you follow them up closely to ensure that they repeat the test depending on their risk status. If they are significant risk, you want to place them on PrEP, you want to follow them up to ensure that they remain negative. And the outcome, ensuring that they remain negative, and also early repeat HIV testing for recent and or ongoing exposure. If this client if the contact of the client is a known HIV positive, so this is someone that is already known, so you don't need to test those ones again, but you want to ensure that you elicit their partners. So you want to, if they are partners only, you want to offer them index and partner notification services. If they are partners and children, you want to evaluate them for ART initiation. Are they already on ART? And are they virally suppressed? You want to also emphasize U equals to U messaging. You want to prescribe TLD as indicated. You want to evaluate them for adherence and engagement in care. Now, depending on this your evaluation, if they are out of care, either they are virally suppressed or not, they're out of care, you want to re-engage them in care, or you want to initiate or reinitiate them on ART. You want to assign them to peer counselor or linkage case manager. If they are already in care, but adherence is a problem, you want to ensure that they have enhanced adherence counseling. You want to also assign them to peer counselor or linkage case manager. If they are not virally suppressed and there's no adherence problem, they want to begin thinking about drug resistance. So you want to evaluate them for drug resistance. And if they're eligible for switch, you want to refer them to the switch committee to consider them for ART switch regimen. Now, for the third outcome, ART initiation same day, viral suppression by 6 months or 3 months. So if they have undergone EAC by 3 months, you want to retest them to ensure that they are virally suppressed. You want to evaluate them for a virally suppressed at the end of 3 months. Then you also want to trace all their partners and offer them HIV testing within 14 days of being named. So essentially, when you look at the response at the individual level, you want to provide them enhanced services that you provide for every newly identified positive patient. But because of the epidemiological role that they play in the transmission of HIV, you want to ensure that you want to prioritize these patients for all these services. Now, at the site level, we should have what we call a Recency Public Health Rapid Response Team, RRT. And their function is to be able to identify every recent case and optimize all the services that we have just talked about for them. And it's everybody's responsibility. So now, what's the composition of this RRT? Number one, we have the SI or the M&E focal person for that facility. We have the prevention or the HTS or the testers for that facility. We also have the lab personnel for that facility, and also the care and treatment. So we can see that it's everybody's responsibility. If you look at the services that we have already talked about in terms of response that's provided at the site level, you can see that everyone has to be involved. Everyone has to be involved. And that's why the composition of this team is very, very important to be able to achieve epidemic control. And the site level has to provide, take responsibility and contribute their quota to this. So for the SI or the M&E focal person for that facility, he or she is responsible for recency surveillance data reporting, responsible for data quality. He or she conducts routine review of recency data or dashboard, coordinates weekly recency RRT team meeting, and also presents recency surveillance data for public health action and response. So on the NDR, we have a dashboard for recency, recency dashboard. This can help us to see if the data that we have on NMRS is getting to the NDR. The role of the SI focal person in that facility to be able to do this. You have to compare what you have on your register with what you have on your NMRS, with what you have on the NDR dashboard. Because if you have the data on your register and it doesn't get to the NDR, at the end of the day, those at the above site level, they are not going to be able to perform their function as needed because of underreporting. Remember when we were talking about the 3 domains of data use, we said the first aspect is quality, data quality. And that is very, very important, even to the level, to the national level. So for the prevention or the HTS focal person in the RRT team, we have the responsibility as HIV testing, as we all know. Recency testing is the person's responsibility. Counseling and partner elicitation, index testing and PNS, contact tracing, linkage to care, HIV prevention services, and repeat testing for negative partner. And for the lab focal person, to ensure quality of the HIV and recency testing, again, bringing us back to the quality domain in data use. Then he or she supports preparation of recency PT and QC panels. Again, this is also talking about the quality of the test being conducted. So from time to time, the contest proficiency testing is usually done 3 times in a year, and the quality control testing is done monthly to ensure that the recency testing that we're conducting in our facilities or even in the community are of high quality. Also to ensure participation in QC and PT program, sample collection for viral load for viral load is also important because what we use to confirm what I would call the RTRI recent, which is the rapid response test recent using the rapid test kit, the Asante kit, is viral load. And we have discussed that before, the basis for doing viral load in them. So the lab focal person is the person that ensures that the viral load for such patients are collected and also ensure that there's a return of the result in good time. So to follow up closely, ensure that the result is returned and also documented. Also coordinate commodity supply logistics to ensure that we don't have kits expiring, we don't have the labels or the kits, being out of stock in the facility. So it's the responsibility of the lab person to be able to do that. And also the care and treatment. Their responsibility is to ensure that the facility linkage to care, ensure same-day RT initiation, ensure viral load suppression for recent cases, ensure viral load suppression for partner already in care, enhance adherence counseling for partners already in care, but that are not virally suppressed, ensure partners already in care are evaluated for drug resistance and potential ART switch if indicated. Now, because before we bring this presentation to a close, I would like us to look at what is being projected right now. We can see that there's a fire getting close to this beautiful community. This beautiful community have houses, have investments in millions of dollars. So this actually happened in 2003 in the United States of America. There was a wildfire. You see that fire was about to engulf this residential community. You know, it's still the same thing if you look at recent infection. We have already been surging for some years now, and we are getting close to achieving that epidemic control. This is not the time to relax. Those recent infections are like the wildfire that are smoldering. And if you are not careful, if you don't prevent them, if you don't prevent them, they are going to erase all the achievements and the gains that we have made through the ART surge. So this picture is just to illustrate the fact that each and every one of us is a firefighter, but a preventive firefighter that will ensure that all the gains that you have made through surge are not eroded. Now, in summary, HIV recent infection surveillance is critical to finding HIV infection at the current phase of the epidemic and the achievement of epidemic control. Recency data use is applicable when recent and long-term infections are identified. For long-term infection, we can use the information to elicit the possibility of clients being previously known positive who might already be on treatment during post-test counseling. For recent cases, data should be used for targeted response to reach partners of the index case. Thank you very much.
Thank you very much, Dr. Nihi, for this wonderful presentation. It is well detailed, and I believe even a new person to recent infection surveillance will be able to grasp the essence of this and what we will stand to gain if well implemented. Do you want to stop sharing your screen now? Dr. Nihi, can you hear me? Hello, Dr. Nihi, can you hear me? All right.
Yes, I can hear you. Yes, yeah.
All right. So thank you very much, and it was a wonderful presentation. So I would like to open up the floor for questions. I don't know if we have questions. Can we use the Zoom platform to raise our hands if there are questions? And I believe this is well detailed enough. Do we have questions? Well, Dr. Nihi, while I wait for questions, I just want to ask a very simple question, simple in terms, like, is there evidence that recent infection surveillance has helped to kind of reduce or control the spread of HIV? I'm aware of the question I'm asking, but for the benefit of those on the call, I just want to find out, are there, critical or specific evidence to show that recent infection surveillance has helped to either reduce or control the spread of HIV in Nigeria, or maybe in any particular state? Maybe we can use Rivers State where the surge started, or any other such state. Do you want to respond to that before we start taking questions from the audience?
Yes, so thank you very much for that question. Yeah, so there's evidence that recency surveillance has helped us to move towards epidemic control. If you look at most of our states, so actually in Rivers that you mentioned, and also FCT, we started recency infection surveillance in 2020, and the output from the recency infection and find those recent cases has helped us to intensify our index testing, and that has also helped us to be able to achieve epidemic control in this state, to saturate this, this state. There are so many evidence that it's been helping us, because if we're not able to identify this recent infection, it's possible that we are going to be wasting resources, really. So we may be identifying long-standing cases, wasting resources, tracking their risk networks, and meanwhile, the recent infection that are driving the transmission, you are not identifying them. So it has helped us to, to be more efficient in our case finding. And in fact, right now, that is what drives our case finding, and it has really helped us. Thank you.
Thank you very much for that. Now we'll have questions from Geoffrey Marcus. Geoffrey Marcus, can you unmute yourself and ask your question? Geoffrey Marcus, I've enabled you. Can you unmute yourself and ask your question? All right, Geoffrey Marcus.
Okay, yes. My question, sir, is does Recency, Asante test kit have any limitation? Can somebody be HIV negative and then RTRI recent or RTRI long term? Thank you.
All right. Over to you, Dr. Ni.
Okay, so just to mention that number one, the Recency test kit or the Asante test kit is not for diagnosis. We just use it for identifying recent infection among those that have been diagnosed positive, HIV positive. So we have the national algorithm for identifying HIV positive cases. So if you have cases where this client is HIV negative, according to the national algorithm, and the Recency infection test is telling you that this patient is long-term or recent, then you need to ensure that you get in touch with your lab focal person and investigate that scenario, because we don't expect that anyone that is HIV negative, according to the national algorithm, should be either recent or long-term, because being recent or long-term is that this one is telling you that that the client is HIV positive. So when we see such cases and we investigate, usually it is due to poor quality tests, and we try to address that issue. I hope I've been able to address that. So number one, it's not for diagnosis, it's for public health use, to be able to identify those that have been recently infected or that have long-standing infection. What you use for diagnosis is the national algorithm, using your test 1, test 2, test 3, usually determined. You go to Unigode, and you now go to this the tiebreaker if the first and the second test are contradicting each other. Yeah. But to also mention, just to remind us, we must not disclose the result of the recent infection to our client. I think we need to continue to mention this. It's not to be disclosed. It's just for public health use, to be able to help us in planning our program, more efficiently. Thank you.
Thank you very much, Dr. Ni, for this. Again, we'll have another one from Dr. Elizabeth, State Clinical Mentor. Dr. Elizabeth, can we have you, can you unmute yourself and ask your question? Dr. Elizabeth, are you there?
Yes, I'm here. Good morning, sir. Thank you, Dr. Lee, for the wonderful presentation. It's very impactful. Please, I keep wondering where you say that partners that cannot be reached, you should give self-testing kits to them. So I want to know how you'll be able to, especially considering someone that doesn't want to disclose her status to the spouse or to the partner, how will you be able to reach such person to do the self-testing? Thank you.
All right, so thank you very much. So when I made that statement, I was referring to you giving the HIV self-test kit to the index case that is before you. As you elicit all these, all these contacts of the index case, it's possible that you may not be able to reach some of them. So you can distribute the HIV self-test kit through the index client. I also mentioned that if you cannot reach them because they are far away from your area of jurisdiction, you can liaise with other partners that are in those jurisdictions or with other states to be able to reach them. And I said that it's important that we work together as a team. There should be this inter-partners, interstate collaboration when it comes to index testing, because until one state is free, other states in Nigeria cannot be free. Thank you.
Thank you very much, Dr. Nihi. So let's take the final question from General Hospital Boni, IHB Rivers Program. Please you unmute yourself and ask your question.
Okay. Good morning, sir.
Good morning.
That is a wonderful presentation from Dr. Nihi. Thank you very much, sir. My own contribution that I want to make in the area of these long time cases itself. These days now we have a lot of long time cases in this area. And these long time cases, they are coming from the hard to reach areas. So in order for we to reduce in the cases of these long time cases, just for we to do more of sensitization in the hard to reach area, or we engage some of the pharmacists or the chemists that are in the hard to reach areas, so that they will be able to be passing out the information pertaining HIV itself, so that those who are that are on the hard to reach area, they will have more information about this HIV stuff, so that they will be able to have that knowledge to be going to any facility that is closer to them for them to get tested and know their HIV status itself. So that is my contribution.
Thank you very much, GH Boni, I think. So let me take this last question and then we'll have Dr. Nihi respond to both of them. This one is from AK. AK, are you there? AK, I'm not able to even allow you to speak. I don't know. So thank you very much. Can you respond to this now, Dr. Nihi?
Okay, so thank you very much. So that was a comment that he made, and I think I agree with him. So it's important that each state, they look at the peculiarity of their state, and the prevention team will strategize their testing, to be able to align with what obtains in the state. So if you have hard to reach areas, you have community teams, you have those that you can work with, you have several strategies that you can use to reach them. But even though long-standing cases or long-term cases are coming from this hard to reach area, if they are not identified on time, if they have ADHD, if they are not on drugs, they are not suppressed, or they are on drugs because they are in hard to reach areas, they are not adherent, they will continue to drive the transmission, all right? And if you are having long-term cases coming from this hard to reach area, and you are also having recent cases coming from this area, the recent cases will be driving the transmission, all right? So it's important that each state, they strategize. They use all the data available to them, both facility level data, system level data, geographic data, to be able to properly plan the testing strategy in the state. Thank you. Just to add to what he has said. Yeah.
All right. This is the last one. I suppose when these questions become very worrying, maybe you could just raise your hands in case if I didn't go through the chat box. So this one is from a clinical mentor in Ocean. He said, "Thank you very much for the amazing presentation. My question is on the last comment about not disclosing the recency status to the clients. He said, I had situation on the instance of the client on knowing the recency status, although I did not tell her, and the reason are quite reasonable to her. How can we go about this?" Dr. Nihi, I don't know if this is clear. Hello, Dr. Nee.
Yes, I said I'm trying to understand what exactly this person is talking about.
Can I read it again?
Yes, so if the person can unmute and make the question clearer.
So a clinical mentor from Osun State, I don't know if you can raise your hands and make your question very clear. What you write, I've just read it the way you sent it, and I don't know if it makes sense to the subject matter expert. Are you there, the Osun State clinical mentor? Can you unmute yourself? Regardless, let me read it again. I hope it makes sense this time around. He said, thank you so much for this amazing presentation. My question is on the last comment about not disclosing the recency status to the client. He said, I have had situation on the insistence of the client on knowing the recency status, although I did not tell her, and the reasons are quite reasonable to her. How can we go about this?
Okay, so I think it's clearer now. So as I said earlier on, one of the eligibility criteria to even go ahead with a test is to ensure that the patient agrees, so you must counsel the patient, the patient must agree, because there's an option to opt out, really. And part of that counseling information that you give is that the test is for public health use and the result is not going to be disclosed, and let them understand the reason why this is so. It's for public health use. It's not going to affect whether they receive services or they do not receive services. And I'm glad that the person that is asking this question did not disclose, but the only aspect I'm not clear about is that, was it after the testing that the person insisted? Because if you are counseled person and person has opted in, a person has agreed. If you are counseled person, I'm not going to tell you. So after you have done the test and you don't disclose, it won't be a problem. So I actually, agree that can be a problem sometimes. But from our experience, really, once you explain all this to the client, the rate of opting out is very low. Because once you start seeing people opting out because I'm not going to tell them the result, then we need to look at the counseling process, again, to see if it's being done the right way, So I hope I've been able to address that question from that clinical mentor from Osun State. Yeah.
Thank you very much, Dr. Nihi. It's been wonderful having you, and I believe all the participants have learned a lot about recent infection surveillance and data use. At this point, I want to ask, can we have a final word from you? And then take a closing remark from the Federal Ministry of Health. Dr. Nihi, can we have a final word from you?
All right, so thank you very much, everyone. Just like I said in the closing remark, that every one of us is a firefighter, but a preventive firefighter. We are celebrating that we are getting closer to achieving epidemic control today. We've made a lot of gains in the past few years, towards achieving epidemic control. Surveillance is very key at this point in time. Recency surveillance is just one. We also have mortality surveillance, and epidemic control. You try to look at your incident cases, look at your number of deaths, among people living with HIV. We want both of them to be reducing, and also for the new infection to even, for the mortality to reduce even more than the new infection, because that is the point that you say that they have been able to achieve epidemic control. Just for us to double up our efforts, I know we are trying all our best at the different sites. That's the reason why we are getting the kind of results, just to encourage us to continue to do our best, to continue to counsel these patients, to ensure that the 95 goals are achieved. Thank you very much for your participation today. Thank you.
Thank you very much, Dr. Nihi, for the wonderful presentation, and thanks for making yourself available to speak to us. Again, let's have Omola Bake Ekundayo to give us a closing remark from Federal Ministry of Health.
Yeah, thank you. Can you hear me clearly?
Yeah, we can hear you. Please go on.
Okay, thank you. Good morning, everyone. I would first of all like to apologize on behalf of the GON. I apologize because we couldn't open the session due to bad connectivity. I really apologize, and I would like to appreciate Dr. Yorishawai. Thank you very much, sir, for the impactful and well-detailed presentation on recency surveillance data use. We really appreciate you for always being there. Thank you very much. And to all our participants, we really appreciate you for always taking your time to join the call. And I believe today's topic, we've really learned a lot and taking back this lessons to things at our various facilities in order to be able to deliver a quality service to our clients, and also to appreciate the IPs supporting our facilities. We really appreciate you for the continuous support and collaboration with the Ministry of Health, and also to the really appreciate you for your usual technical support, and also to all other persons that I'm unable to mention that on the call this morning. Thank you, and to our SMEs that are always there. Really appreciate you, and I would like to close the meeting today on behalf of the Federal Ministry of Health, the leadership of the NASCA, Dr. Adepobola Bachoru, and I wish everyone of us a successful Thursday. Over to you, Professor. Bye for now.
Thank you very much, Labake. Thanks to the Ministry and NASCAP division for all your support. And from all of us here at Vice True, I want to say thank you. We look forward to having you again next week. Next week is our special facility case presentation where we'll be taking and learning from one of our facilities. Please do make it a point to do create time for us to meet again next week for that case presentation. Thank you very much, and bye for now.